I wanted to introduce Mike Levas first. He is Associate Professor of Pediatrics in the section of Emergency Medicine at the Medical College of Wisconsin. And he's also the Assistant Director of Project Ujima, which is the premier hospital youth violence prevention intervention program in the United States. And I wouldn't argue with that. It's actually one of the first. And we all look to Ujima as one of the programs that, for a hospital-based violence intervention program, has done so much in the community. And I think you're going to hear some of that from Mike. So,
thank you.
Thank you. Yep, you go up there, and there's should be in the slide advancer.
Mm-hmm. Where is the slide advancer?
It should be down arrow.
I am. Escape.
Up there.
Maybe go down here.
Mm-hmm.
There.
How many doctors does it take?
A lot. All right, thank you. Sorry for the technical difficulty there. So again, good morning. Thanks for having me. My name is Mike Levis. I work as a pediatric emergency room physician at Children's Hospital of Wisconsin. And I also am the assistant medical director of Project Ujima, which Joel nicely introduced as a violence intervention program that has been around for a while. Some of the things that I want to talk about today are what Project Ujima is, and then how we've kind of started delving into research agenda to supplement and complement our service agenda. And then I also want to talk about how Children's Hospital of Wisconsin has been an early adopter in really recognizing how a hospital can push forward a mission to try to combat violence in the community that it serves. So I'll be speaking about another project that works on pushing the Cardiff Model forward that we've implemented at Children's as well. So really at Children's, we really recognize that youth violence is a multifaceted problem, right? So there's the individual victim who has their own story to tell, their own input into this issue. We have the community that they come from. We have the healthcare system that traditionally has been a kind of patch up and send back out to the community type of system. And then we have law enforcement and police, and all that really intersects in the middle. What Project Ujima is a program that really started after we had our legacy child. We'll call him Jason. But about 20 years ago, this child ended up in our ED at 16 and was dead from multiple firearm injuries. And one of the nurses there recognized the kid from a visit before. And when they looked back at his history, at 8 he had come in and had an accidental injury. At 11, he was assaulted. At 13, he was stabbed. At 15, he was shot. And at 16, he was dead. So we had missed opportunity after missed opportunity after missed opportunity, and the result was a dead child. And from that, the Project Ujima was really born. The idea was that, can you imagine if we missed cancer this many times? That would not be something that would be acceptable to us. So we know that kids who are victims of violence, a lot of times there are things upstream that could flag them as potential future victims of more serious violence. And what we do at Ujima is, if you come in and you're a victim of a stabbing, physical assault, or a gunshot wound, we have a Ujima worker who comes to the ED and tries to enroll the family. And our first thing that we do is we try to preach non-retaliation. We know from the Milwaukee Homicide Review Commission's data that 50% of our violent injuries and deaths result from arguments or retaliation. So that's the number one issue in Milwaukee that we try to stop. After that non-retaliation, we basically wrap those kids in services. So each individual is assigned a case manager, basically, and we work from the beginning of the trauma. Some of it is physical. We help them get to their appointments. If a child has been shot and now has to use a wheelchair, we will help to get their house ADA compliant. If their front window was shot out, we will replace that window. If the place that they were injured at causes a lot of re-traumatization, just from being there, we will help them get out of their rental leases. We will get them with lawyers. And then we have lots of programming directed at the kids themselves. So we have after-school programming for our adolescents and teens. We have summer camp, which basically takes about 60 of our youth in Milwaukee who have been victims of violence, and we, during the most dangerous times of the year, we get them into a safe location and have a camp where we talk about empowerment, leadership. We have classes that are range from hygiene for some of these kids all the way to using chess as a means to think about conflict resolution or conflict avoidance. These are numbers from 2017. So we had 178. The vast majority come in through the ED. You'll see the 126 homicide. Those are homicide survivors. So we've actually expanded. We know that vicarious trauma is just as affecting as direct trauma. So 126 kids whose direct family member was killed. Those were also served, and then we had another 34 DVs. So just in 2017 alone, we had 338 participants in Project Ujima. That's just one city. That's just Milwaukee. It's a lot. How did we delve into research? So traditionally, we had to report how many kids we served and how many kids signed up for programming. And one of the things that in this work, if you work in it long enough, you're going to have people that question what you're doing, how effective you are, how do you know that your outcomes really matter? And it's really hard if we sign up a kid at 8 to tell you that, yes, they successfully graduated high school, because that's a 10-year gap there. So what we started looking into was something called patient-reported outcomes, which are outcomes that look at the individual's well-being based on their own reporting. They tend to be in other disease states. It's used in adult diabetes, adult cancer, child cancer, a lot of childhood traditional disease processes, and they've found to be more sensitive than looking at lab numbers alone and how the individual actually is doing. So what Ujima has done to date is we've actually shown that it's feasible in these kids to use the validated patient-reported outcomes measures. And I've put up there 2 publications so that you guys can look them up later. But we really were able to show that our kids who are victims of violence and even vicarious violence or vicarious trauma, they actually show worse quality of life measures than youth with chronic disease, let alone kids who don't have anything in their past medical history. And then we're also able to show that after our summer camp, we could improve those scores. So you can see here that when we looked at youth victims of violence compared to healthy individuals, and then one of the other things we thought is, so 85% of our participants are African American. We actually compared to a healthy, racially similar group, and our kids still score significantly lower along physical functioning, psychosocial functioning, emotional functioning, and school functioning. And when we compared to kids who have other chronic disease states, our kids actually scored worse in psychosocial functioning, emotional functioning, and school functioning. So at our hospital, we've had a lot of money that's been put forth towards fighting the obesity epidemic. And a lot of attention has been put into how these kids actually feel, how they function. But our kids are doing just as bad. And this was an opportunity for us to show leaders in the board and to reiterate the importance of the work that we're doing. This was actually more impactful. You might be able to argue that being a victim of violence is as bad as having cancer. Psychosocial functioning, emotional functioning, and school functioning, our kids are doing poorly. And one of the questions we get as to why that might be, why it would be worse to be a victim of violence than to have cancer, is because we have a cancer floor at our hospital. We have a cancer team that just focuses on psychosocial interventions. We have Packers and Brewers and Bucks, professional sports athletes, who come and visit that floor. We surround those kids with tons, and families with tons and tons and tons of support. And comparatively, our kids who are victims of violence, I don't think are seen in the same way. So the next question that we had after showing that our kids had really impaired scores was, can we do something about it? So what we did was a pre and post study after our 6-week Project Ujima summer camp. And summer camp, again, is a program that really tries to provide a safe environment for those kids who are at increased risk during the summer, but then tries to do enrichment type of programs. And we were able to show that after our 6-week intervention, our kids were, their scores improved. So their emotional score improved, their psychosocial score improved to a statistically significant level. We worked on a lot of other measures, but because we only have 20 minutes, I can't show everything. I had to pick and choose which slides I wanted to share. But this repeated with PROMIS measures, which are the validated NIH patient-reported outcome measures. We were able to improve depression scores, anxiety scores, and also improve anger. I should go back. Those last slides that I showed, again, those were repeated across the NIH PROMIS measures as well. Our kids scored significantly worse with anxiety and depression, and specifically anger. Our kids are angry. They're constantly being traumatized, and they are always in those early stages of grief, I would say, where at first it's denial and then it's anger. And they keep getting re-traumatized and go back into those zones. What are we doing now? So with Project Ujima, we're looking at how much of these scores are due to the actual violent event and how much of it is because of location. So Milwaukee is the most segregated city in the country. We are looking at enrolling youth victims of violence and then matching with non-violently and non-injured youth from the same neighborhoods, matched on gender and race. And what we want to do is try to take into account how much of the social determinants of health that are impacting them from their built environment. We also have taken this research, so we used this research to show that these measures were important, and now we have them integrated into Project Ujima outcomes measurements. So we've used this data to really translate this into what we do on an everyday basis. Every kid who comes in now has a baseline score for patient-reported outcomes, along with other measures that we tied in there. So we look at their baseline ACEs score, so their adverse childhood events. We look at PTSD, and we follow them every 3 months with these standardized measures in an attempt to really find out which kids are being impacted most by our intervention. So traditionally, we had a blanket approach with Project Ujima where every kid would get just about every intervention. But we realized that we could be smarter and more targeted if we look at the kids, look at their scores, look at the interventions that are being done, and really try to hone out which kids might really benefit from camp and which kids don't. Which kids need the behavioral specialist early before any other programming is going to really affect them, to try and identify them quantitatively. We also know that our blind spot is prevention. So everything I've told you about Project Ujima has been reactionary. Part of that is because of the funding stream, and I apologize I wasn't here yesterday, but I've been told that a lot of talk was about how different funding streams affect what kind of intervention or programming you have. Our funding has been from the Victims of Crime Act dollars, so traditionally we have not been able to do anything preventative because it's for victims of crime. But what we're trying to do now is look at markers in our kids and descriptive variables for our kids and their experiences beforehand, so that once we do have dollars to try and do something more preventative, we already have identified which kids were at risk, so that we don't have the same thing happen where a child comes to the ED and is missed over and over again before they're dead. Now, the hospital I'd like to really call out, I'm proud to work for Children's Hospital of Wisconsin and the medical college because they were really an early adopter of, Ujima does not make money for the hospital. It's the right thing to do, and the hospital recognizes that. The hospital matches every VOCA dollar that we get. The hospital has also been an early adopter of other violence prevention and intervention initiatives. And one of the ones I want to talk about is one that the hospital partnered with really early with the medical college is Comprehensive Injury Center. Looking at how does the hospital system interact with law enforcement and police to try to tackle this issue. So for those of you that aren't familiar with the Cardiff Model, it was developed in Cardiff, Wales, and basically it is a way to get a better map of where violence is occurring in the city, because what they found in Cardiff was that the vast majority of injuries were not being reported to police or law enforcement, but a lot of them were going to seek medical care. It hadn't been attempted in the U.S., and under the leadership of the Children's Hospital and the Comprehensive Injury Center, we attempted to look at, see how this Cardiff model would look in Milwaukee. And there are a couple, Atlanta was also doing this project as well. So basically, Children's, when we went to Children's and said we want to do this, they said, absolutely. We're already collecting most of this data. Why not partner? So for 3 years, we've been collecting data. We've maintained a 98% screening rate, so every single kid that comes into the ED is asked, are you here for an injury? And if that answer is yes, was this injury an assault? And if that answer is yes, then there's 7 more questions that really look at, or they are trying to get to where the injury happened, what kind of weapon was used, what time of day, et cetera. We've also partnered with Freighter, which is our level 1 adult trauma center, and they've been collecting data since 2018. And we've brought in 2 other community hospitals, specifically in West Dallas, Aurora St. Luke's and West Dallas Memorial. What we found looking at pediatric injury data is, and this is a pretty busy slide, but the gist of it is about only 7% of the records of the violence that presented to children's, only 7% did the police know about. So, huge gap. The police are working on maps based on their own data, right? Public health is working on interventions based on police data. We showed that with youth, they're missing a large percentage of these potential catches for kids who are at risk. So if you look at the map on the left, that was the police data alone. And you can see that there is a hot spot in kind of the mid-central city, and then another hot spot down on the south side. So that's what the police knew about with youth violence. When we added in our data from EMS, so we also had EMS data. When you added in the ED data, EMS data, you can see that another hot spot pops up. Police knew about none of those. You can see that that south side is less impactful. So this was another opportunity where the hospital was able to add to the narrative of where intervention should be done and really try to help the civil society really get a better information to work on. So in conclusion, I know my 20 minutes is up. I get to talk for a lot longer. But really, hospital systems can play a vital role, both in the intervention portion and intervention portion of violence, but also in the surveillance and thinking outside the box and how do we work as a health system and a city and a community together to really tackle some of these problems. Please ask me questions afterwards. I'd be happy to talk more about both of those initiatives if you have any questions. Thank you for your time.
Thank you, Dr. Levas.